Good afternoon. Welcome to Digipath Tutorials. Today we would like to discuss an unusual case of amyloid goiter. We had a case of a 40-year-old male with diffuse large firm thyroid enlargement who presented with difficulty in breathing and hoarseness of voice for the past 6 months. Thorough investigations revealed cardiomyopathy and signs and symptoms of renal amyloidosis. Recently, this patient developed stridor and was admitted to the emergency. A total thyroidectomy was carried out by the surgeons to alleviate pressure symptoms. We received a thyroidectomy specimen measuring 8 into 6 into 4 centimeters in size. The whole thyroid appeared to be diffusely enlarged. The external surface was well encapsulated and had normal contour. The whole thyroid was firm to hard in consistency. The cut surface was homogeneous, brown tan in color, and waxy. There was marked nodularity, no hemorrhage, necrosis, cystic degeneration, or any other gross lesion was identified. Multiple sections were taken. On low power magnification, we can see that the thyroid appears very pink. There are fewer number of thyroid follicles. When we go to high power, we see that the thyroid follicles are widely spaced out. Some of them are cystically dilated and have no intraluminal colloid. The thyroid follicles were also reduced in number. There is intercellular deposition of an amorphous pinkish hyaline material. To determine the nature of this hyaline material, we performed a Congo red special stain. We can see that the hyaline material, eosinophilic material, has stained a deepish red or salmon color, and there is no staining of the other thyroid follicles. We also performed a special immunohistochemical stain, serum amyloid A protein. We can see that it was positive in this case with the brown staining of the intercellular material. SNAA stain is usually positive in cases of secondary amyloidosis. A TTF stain performed highlighted the thyroid follicular epithelial cells with no staining of any other areas. A calcitonin stain was performed to rule out the possibility of medullary carcinoma of thyroid, and it was negative in this case. Based on morphology and Congo red staining, a diagnosis of amyloid goiter was made. Immunohistochemistry is not required for diagnosis in this case but is helpful in differentiation from medullary carcinoma with marked amyloid deposition and also for academic interest. This patient unfortunately succumbed to cardiac complications 3 months after the surgery. Amyloid goiter was first reported in 1855 by Rokitansky, and it is also known as amyloid tumor of thyroid. It is defined as a diffuse clinically apparent enlargement of the thyroid due to widespread amyloid deposits. It's a rare entity and the diagnosis is often made at autopsy. Patients usually have normal thyroid function tests and only a minority have altered thyroid status or thyroid autoantibodies. The median age is around 54 years and it is more common in males. In adolescence, it may be associated with juvenile arthritis or familial Mediterranean fever. Most cases of amyloid goiter are due to systemic amyloidosis. Secondary AA amyloidosis occurs as a result of chronic inflammatory conditions such as rheumatoid arthritis, Crohn's disease, familial Mediterranean fever, osteomyelitis, or tuberculosis, resulting in increase in serum amyloid protein. It has also been reported in dialysis dependent chronic renal failure patients as a result of beta 2 microglobulin accumulation. Clinically, these patients present with a non-tender diffuse enlargement of the gland over weeks to months. They may have obstructive symptoms of dyspnea, hoarseness, and dysphagia. Grossly, depending on the amount of amyloid deposited, the thyroid can be soft, hard, diffuse, or nodular. And generally, there is bilateral enlargement with nodules and a whitish tan, light brown, or pale yellow cut surface. Microscopically, there is diffuse deposition of amorphous eosinophilic fibrillary material in perifollicular and perivascular regions, which may replace thyroid follicles. You can have other associated findings like fatty metaplasia, a foreign body giant cell reaction, squamous metaplasia, or focal lymphocytic thyroiditis. So, the take home messages from this case would be that we need to keep unusual possibilities in mind when we are examining diagnostic biopsies and pay attention to minutest details. And it is very easy to miss, for instance, fungal organisms if sufficient time is not spent while examining the slide. And our index of suspicion should be high to detect unusual pathologies. We should also not be carried away by clinical diagnosis and make generic reports like chronic inflammation, no evidence of malignancy. Such reporting is unjust for the patient as he or she will not get timely treatment, and we are not really giving the clinicians any pertinent diagnosis. We also have cases of amyloidosis of other organs in the Digiscan histopathology set for benefits of users and subscribers. So please have a look at them. We have more digital slide sets available also on our website. Thank you.